Well, thank you all for joining us for this inaugural East Transition to Practice course, session one. Hopefully, we will sort of show you over the course of this session and the subsequent three that there's a lot of useful information that we have to give you guys to help you, as you kind of transition from trainee and go out into the real world. I will just preface a lot of this by saying that this is not a lot of scientific, it's not evidence-based, so it's very, very contrary to what you're typically used to hearing and seeing. But I still think there's a lot of value in it based on a lot of experience from a lot of different people that have put efforts into this course. So thank you very much for joining us. My name is Avi Bhavaraju. I'm the chair of the East Mentoring Committee. I'm a surgical intensivist at Grady, associate professor at Morehouse and Emory School of Medicine. And there's a lot of people involved in this course. Today we've got several speakers, and throughout the course of the remaining sessions, I have additional people coming to speak to you guys with, I think, a lot of beneficial and useful information. But at the end of the day, you're the sort of end product. You guys will let us know how useful you actually think it is. So we'll start off a little bit about what is TTP. So it's the Transition to Practice course, which, it's fairly self-evident what that means, but in reality, what does that actually mean and how do you transition to practice is really the nuts and bolts of why we're doing this. It's a four-part series. Each session will be about 60 to 90 minutes. Dates there. So today is the first session. Second session will be early August. I think August 7th is the date we have targeted right now. And then sessions 3 and 4, September, October, and November, December. Session one, so this session will be basically an introduction is what is TTP, why do we need it, do a little bit of some basics on billing and coding, a little bit about the business of acute care surgery, talk about practice types. In August, we'll talk about job searching, contract negotiation. September, October, session three will sort of a big blanket of insurance 101, sort of all things insurance related. Session four, we'll talk about retirement and financial planning and also adverse events. As I mentioned, these are brief presentations. It's not really scientific in nature. There's no studies or anything. It's really largely experiential, but based on a lot of good experience with a lot of people with a lot of varying levels of experience. And then we'll follow that with an interactive Q&A session for all four sessions. And then another thing I think that will distinguish us from perhaps other products out there is, the goal is really to provide ongoing follow-up advice and resources. So this is not really meant to be a one-time shot, give the information to be done. We'll provide you resources to some follow-up on your own, but then also for us to provide you ongoing feedback and support as you kind of engage in this process. Because as you all know, this is not a one-time set it and forget it thing. You're the process of transitioning into practice starts the spectrum from really throughout your entire residency, certainly in the last year of your training or fellowship, but even as you transition into your first practice, a lot of these things are still very relevant. So why do we need TTP? How did this kind of come about? And the reality is that this has primarily been sort of a brainchild of mine for the last, probably 7, 8, 9 years. And realizing that in GME, in traditional GME training, we spent a lot of time and a lot of focus on teaching you the medicine, teaching you the surgery, teaching you technique, like how to be a good physician, how to be a good surgeon. But what we don't do is spend a lot of time on how to teach you and help you successfully enter the workforce. And this happens on a lot of places on sort of one-off bases, and people with some experience having one-off conversations with residents, and what should you look for jobs and how do you approach that, and I think really it's because there's a systemic lack of education. So there's a lack of systemic education on some of these issues. So like so you're looking for a job, but how do you actually find a job and really critically evaluate opportunities? There's not a lot of that goes into that, and sort of giving you techniques and methodologies for how to approach that. How do you approach contract negotiations? Like, sure, you sign a contract, well, it's not really that straightforward. How do you advocate for yourself, right? How do you understand the business of medicine and surgery, which, whether you like it or not, the reality is in healthcare in 2025, medicine is a business and you are a part of that. And if you don't really understand the ins and outs of some of this, you really can make mistakes and potentially set yourself up for problems in job searching and your career moving forward. And then really, I think, at the end of the day, it's how do you enter practice and really set yourself up for long-term success? What you'll realize as you kind of get through this, hopefully through the course, and maybe when you get into practice, is you'll realize that it's not just a matter of showing up and working hard. right? That's what we're all accustomed to doing. And you think that, yeah, I'll just show up and do my job. But that honestly does not oftentimes lead to success. And I mean that in a very broad sense, not just professional success, but really personal success is a big part of this. And realizing that your global success as an individual, both personally and professionally, has to do with both of those things, not just work success. And really, I think this is another key point is focusing your job search and your career development on what you truly want, right? Not some perception of what you think you should be doing. And so I kind of to distill it down, I think the core of TTP really focuses on these five things, and why it kind of came about is finding and evaluating a job, how do you advocate for yourself, understanding the business of medicine, and focusing your thoughts and your decision making on what you really want to set yourself up for success long term. So how did this kind of come to be? You know, as I mentioned, it's really personal experience, a lot of anecdotal experience, primarily from me, because this is kind of my brainchild, but also through many conversations with a lot of colleagues, a lot of surgeons, a lot of trainees over the course of my career, realizing that we just don't do a good job of that systemic education for not just the technical part of medicine, but the other aspects. And so my story was, you know, I finished fellowship in 2012. I started my first job. And when I started, again, this is all in hindsight, I didn't have any knowledge, really, almost nothing about how to actually enter practice and how to be a functioning adult in the healthcare system. And I mean that very generally, like, I mean adult, like both professionally and personally. So like when I came out of training, I had zero knowledge about mortgages, zero knowledge about life insurance, disability insurance, malpractice insurance. And again, a big part is how do you critically evaluate a job? So I got, you know, lucky I had a good job, but I didn't really, I kind of looked into it rather than having a systemic approach or systematic approach for how to do that successfully. I also had minimal knowledge about billing and coding, almost nothing about practice operations and management. I was lucky that in my fellowship, I got some education. Like I even knew what an RVU is. And, you know, most trainees at that time didn't. I think trainees now are a lot more savvy. They have heard the term, but maybe don't necessarily understand what that means and why that matters. And I think through the course of this session, we'll show you and prove to you why it's important you know some of that stuff. I had very little focus on what I wanted, but really mostly what I thought I was supposed to do. And that'll be another thing we sort of hammer through the course. This course is really refocusing your attention on what you truly want in your core and your heart, not just professionally, but also personally, rather than some perception of what you think you should be doing because somebody told you this or because it's sort of been hard baked into you during your training. And, you know, I say this as I got lucky. I had no major financial errors. I made one small one. I had a good first job and I had great partners. And I just got lucky because I didn't really approach the job search systematically because I didn't really have a significant amount of guidance or mentorship. I trained at a small, you know, hybrid community program. There wasn't a lot of investment. There was not a lot of mentorship. And so I got lucky, but, you know, I also in medicine as it is in your life, like I tell my residents and fellows all the time, you know, clinically everything's fine until it's not. Well, it's kind of the same thing here. I got lucky. I got a good job. I had good partners, and I, by and large, for the first 3 to 4 years of my career, it was great. And then it wasn't. And so this also sort of rolls into how transition to practice really is not just entering your first job, but let's say you enter your first job and things change. How do you then reassess your situation and your goals to then realize maybe it is or isn't the right situation to continue in, and how do you make that change? So a lot of this is relevant to that as well. And our goal is really to help minimize these issues and challenges so that you don't struggle with those situations if they do come up. A lot of this came about through one-off discussions with a lot of trainees, a lot of colleagues, and you know I've felt this way for a long time. But the more people I talk to, people at my level, people senior to me, people younger than me, realize there's such a gap in how we educate trainees to enter practice. Like I said, we do such a good job of training you the medicine, but we don't really prepare you to how to enter the real world and be successful in practice, both personally and professionally. So again, a lot of discussions, a lot of mentorship, and then I took over as chair of the East Mentor Committee last year. Even more discussions, and I was luckily, you know, this idea I've had for many years was able to actually operationalize through East and through a lot of colleagues and a lot of support to put this course together. So this course is many years in the making, but really in earnest about the last 14 or 16 months to try and put this product together that you guys are participating in today. So again, our goals here is really to educate, to empower, and to advocate. At a very core level, that's what this is about. Because knowledge is power, right? Knowledge that you have will help you succeed moving forward, and lack of knowledge really disempowers you and increases risk, right? Risk for financial problems, risk for making mistakes in job searching, in entering a job that you didn't realize was actually not a good fit in the first place. So it's really about educating you and empowering you to make better decisions moving forward. And again, advocacy, right, for yourself and for your colleagues. If you don't know something, then you can't possibly help advocate for yourself, and recognizing that some situations you may walk into are not really a good fit. But if you don't know any better, how would you be able to make that discriminative judgment? So a lot of advocacy is involved. Networking and relationships, right? There's a lot of talk now about building teams. Well, that also applies to your career and your career success. Is nobody can do this alone. I mean, maybe some people can, but they make a lot of mistakes along the way. Our goal here is to help you minimize the mistakes and achieve personal and professional success long term. And this, I told Salina I was going to put this in there. This, at the heart and the core of what I think this comes down to is a lot of it is freeing you from the shackles of your expectations. And she summed it up. This was not my line. That's why I gave her credit for it. When we were talking about this course last year, she said this line in one of our meetings, and it really stuck with me. It's because I know a lot of you, for me included, a lot of my job searching and job approach had to do with what I thought I should be doing. And maybe it was understood or just misunderstood on my part. Maybe it wasn't explicitly said, but we all feel this pressure to take a certain path or take a certain job because we think that's what we're supposed to do, or rather explicitly or implicitly what people tell us we should do. So a lot of the goals here is to really free you from those expectations and help you refocus your thoughts and decision making about what you truly want, what's going to make you happy, not just professionally, but also personally. And also to spread the word. Like, our hope is that this will, with our small set of people to start with, and you talk to your friends and your colleagues, you see value in this and spread it out to everybody, because this is not just relevant to surgical trainees. It's not just relevant to people in trauma. We're obviously using EAST as the vehicle because of the resources and the leverage it can provide, but this is relevant to all GME trainees in every specialty across the country. And again, a big goal is to provide ongoing support rather than just lecturing at you and telling you things. We feel strongly that we should provide ongoing support and resources. Again, based on a lot of conversations with a lot of trainees, this is not just a one-off thing. Situations come up, you want to talk things out. You have, resources for billing and coding, contract negotiations, all those things we hope to provide for you moving forward. So that's kind of just a basic introduction. Our first general topic is going to be sort of the basics of billing and coding. Our primary speaker is Dr. Samir Fakhry, who's very, very well experienced in this. I'm just going to kind of give you a brief intro as to the why this matters. And in truth, it's primarily because trainees and early career surgeons, generally speaking, have a limited understanding of the billing and coding system. This is pretty much universal, myself included. And so why does it matter? Like, some of you may ask me the question, well, what does it matter? I have billers and coders, or I'm going to have billers and coders, or the hospital will do that for me. And that's all well true, and I don't minimize that by any capacity. But what I would suggest to you is this. This is the system you're going to be held accountable to moving forward in your career, right? This is how your work product and your clinical efforts are tracked. So you really, at the end of the day, should get credit for the work that you're doing. Now, we all sort of simplistically understand or believe that, yeah, the system's set up. Of course, it's going to give us credit for the work we're doing. It's not a big deal. But what I'll tell you is that, having been in practice now 13 years, that's not always the case. And mistakes get made. Everyone's also human, but the system in general is not necessarily set up for you to get credit for everything you do in the way that you do it. And if you don't understand this system on a basic level, you are very likely going to get taken advantage of. So I'll give you an example. Let's say you do a case, and maybe you don't know what an RVU is yet or not, but you will in a few minutes. But let's say you do a case that's, based on your knowledge, it should be a 50 or 80 RVU case, which is a fairly moderate, high level of RVU generation for a general trauma surgeon. And you know this, but the way that the system gets tracked, you're only getting credit for 30 RVUs. Well, if you don't know this and you're not able to audit that and ask the right questions, then you're not getting credit for those cases the way you should. Well, now take that and multiply that by 5 cases a day, 50 cases a month, how many cases a year. That's a significant amount of credit that you should be getting that you're not. And what does the credit matter? Well, a lot of your financial incentives really have to do with RVU generation. And so if you're working 10,000 RVUs, you're only getting credit for 6,000, right? Does that seem fair? Probably not. But if you don't understand the system on some basic level, you're very likely to get taken advantage of in that regard because you don't know any better. So our goals for this section really are not to make you an expert by any means. It's a much bigger topic than we can possibly cover in this session, but really give you a basic understanding of the system and emphasize the importance of why you should understand this and why it matters to you on a tangible level in your day-to-day lives. And then really all to provide resources, right? The goal here is to give you an introduction, an understanding of why it matters, and then give you resources to go educate yourself moving forward to really increase your level of complexity and understanding of this system. I will tell you the one key thing, if you take nothing away, is that proper documentation and detailed documentation is really, really important. Even if you have billers and coders who are billing for you and doing that work, they can only bill based on what you document. So based on the same example I gave you, if you do a 50 RVU case, but you document things inappropriately, and you're only getting credit for 30, well, that's a big shortfall in what you're actually doing. So understanding documentation is a real significant part to this process. And again, advocacy, right? Billers and coders are not perfect. Mistakes get made. And I will tell you, this is just an anecdotal experience. In my 13 years, I've been in 4 different hospital systems. I would say routinely, because I'm very savvy on this and got keyed into it early on, billers and coders downcode us probably in the factor of 15 to 30% fairly reliably in terms of what you actually get credit for and the work you're actually doing. And if you don't understand this and have a basic understanding of the system, you can't possibly check that process. So again, it's advocacy for you and the work you're doing. You're getting credit for the work you're doing moving forward. With that, so here are some general basic billing and coding resources. We can send these links to you later on, so don't worry about snapping it. But the ACS billing and coding course I took 3 times within my first 3 years coming out of training is fantastic. It's very, very detailed and very helpful in terms of giving you a good understanding at multiple levels. And then as you get kind of further on, the TCAA, the Trauma Centers Association of America Basic and Advanced Trauma Center Finance courses are fantastic as well. I've taken both of those. So as you move forward, if you do have an interest, I would highly suggest taking these courses. They're readily available online, and they're a little bit costly, but oftentimes if you play it right, you can actually have your hospital or hospital systems pay for these, or it can come out of your CME expenses as well. So with that, I will hand it over to Dr. Fakhry, who will do our first major session on billing and coding.
Great. Thanks very much, Avi, and good afternoon. I guess it is afternoon where most of us are to everyone. Thank you for the invitation to participate. I appreciate Aaron and Christine's help in making sure we get this going. I'm going to go ahead and share my screen, and hopefully it'll work because we did check it before. If somebody could just say it's working. So,
yep, you got it.
Thank you.
Working.
Very much. Well, so the assignment is what you see right there, and what I'd like to do is just get started real quickly by telling you that this is a bit of an alphabet soup. We're going to be talking about a lot of different abbreviations, so I'll do my best to make sure it's clear. And given the limitations of time, I can't get into it too deeply, but we'll talk a bit about the RVUs that you heard mentioned, and we'll talk about the system by which we define what we do as an activity. The current procedural code system, or CPTs, is a system that numbers things, and there's a set of numbers for procedures, and then there's something called evaluation and management codes for non-procedural activity. I also like to talk to you a little bit about the global surgical package and the role of modifiers, and I'll do that briefly. And I'm going to be talking exclusively about what's called professional fees, or what we sometimes call pro fees. And that's the how and what of how physicians and other non-physician practitioners like mid-level providers get paid. It is related to what you do and has not much to do with what the hospital gets paid. So DRGs, case mix index, the UBO4, and any of the other hospital side concepts are not going to be things I'm going to address here. You also will not hear me talking at all about the billing process. We frequently say coding and billing, but what we really mean is documentation and coding. Billing is a complicated process that happens in the back office. And we're really not in a position to talk about that. And you probably need to know only a little bit about that, which will be a different talk at a different time. So as you probably heard already from Avi, in no way, shape, or form is this meant to be a comprehensive presentation. This is sort of the amuse-bouche, the appetizer, the thing that gets you interested enough to go and learn more, because this is a complicated subject. It was not designed to be easy, by the way, or accessible. So you'll learn about this from your colleagues, from the coders at your facility, and from courses, as you saw. You'll learn about it from reading references and whatnot. I really think it's important to mention that don't be afraid to ask. This system is not logical, or it doesn't always make sense, and asking is absolutely fine. And so if you want to put questions into the chat, we'll try to get to those towards the end. So why does it matter? So Avi made a really good case for it, so I won't spend too much time on it. The RVU system originated 35 odd years ago, and it's a way to reproducibly evaluate what was done by one person and compare it to what was done by another. So it's a method for comparing things. The CPT codes are what describes in numeric terms what was done, whether procedural or non-procedural. So the E&M, Evaluation Management System, is part of the CPT system, which, by the way, is owned by the American Medical Association. So these are national standards, they're reproducible, and our friends, the payers, use them exclusively to pay for physician services. So it's important that we know something about them, or somebody in our group knows something about them. And this allows comparisons, by the way, between and among surgeons. So the relative value unit is part of a system that was developed with input from researchers at Yale, if you want to blame someone, and it's part of a greater, bigger piece called the resource-based relative value scale. It's a way to quantitate effort. And so if you think about it, an RVU is a value assigned to something you've done, either an operation or an E&M. And it's used, again, to calculate reimbursement, so the insurance companies figure that out that way. It's also a way for people to track what you're doing and whether you're doing enough. And performance analytics is the process of analyzing what physicians are doing and comparing them to each other. So RVUs, if you already know this, I apologize, but it's a little bit more complicated than an abacus, and it's sort of like what you see in the bottom diagram, one of the old computers way back when. There are three main components to a relative value unit calculation. The biggest share, a little over 50%, is the work RVU, or WRVU. It's figured out by looking at how much skill, time, and training is required to complete the service. There's also a practice expense portion, the RVU, a little around 40%, has to do with the expenses associated with running the practice, et cetera. And again, a lot of this will turn out to be office-based, and that's one of the weaknesses. And then the third component is the professional liability portion of the RVU. It's the smallest, and it factors in the costs of malpractice. Medicare then calculates reimbursement by then applying an additional variable called the geographic practice cost index, because costs are different in different parts of the country, urban versus rural, coasts versus middle. And then, in case you are keeping up, the conversion factor is used to take that value that has come up and turn it into a dollar amount. And that conversion factor is a very contentious thing that every year gets fought over between physicians and Congress. And currently it's at 32.3456. So if something is a 10 RVU activity, the amount Medicare will pay for it has to go through all of this and then get multiplied by 32.3456. I'm going to skip this and come back to it in a second. So if you're not familiar, if you are familiar with this, I apologize. I'm going to just go over it quickly for completion's sake. But so E&M codes, evaluation management codes, describe physicians' non-procedural activities, sometimes referred to as the cognitive services, as if procedures were not cognitive, but we'll let that one go. So procedures get a CPT code assigned to them, and evaluation management services, non-procedural activities, get an E&M. And whether you're doing a procedure or an E&M, the concept of coding says we're going to figure out a number, a numeric descriptor that says, what did I do? And then we're going to attach that to a medical diagnosis that corresponds to the reason or the explanation for what was done. As you, I'm sure, know, ICD-10 has about 60,000 codes in it, and almost 58% are injury-related because of sidedness and all of that. And so what we do is, in a clinical activity, for example, you see a patient on rounds on hospital day 2, admitted for rib fractures the night before, pulmonary contusions, moderate hypoxemia, and of course, pain. And you then document a really good note, which is, as you heard from Avi, one of the most important things you can do as an individual is to do appropriate comprehensive documentation that fairly reflects what you did without pushing it too much either way. And that note has in it the key diagnoses and satisfies the complicated elements that we will not get into today that make for complex decision-making. Once you've done that, either you or your coder or the two of you working together choose the appropriate E&M code, and I'm giving you 99233 here as an example. That's a very comprehensive activity for follow-up care. Then you have to match it up with the appropriate ICD-10 codes. The CM means clinical modification with the diagnostic codes. And here I picked the ones you see there. So if you do all of that, then you've done a really good job with this. And to give you an example, I'm going to go back to this slide. How do RVU values compare for different things we do? For instance, a laparoscopic cholecystectomy has a work RVU of 10.47. Just so you want to get an idea, the total RVU will be about twice that much. But we're mostly concerned with work RVUs, and when they calculate how well we're doing, they're looking at our work RVUs. A splenectomy, for example, is about twice a cholecystectomy. And critical care, which is an E&M activity, evaluation management, an hour of critical care is 4.5 RVUs. So if you want to think about it, if you take an hour to do a lap chole and you do critical care for an hour, you're going to get paid twice as much for doing lap chole as you are for doing critical care. That seems initially unfair, but remember, they're paying you not just for the lap chole, but for the care that would normally be associated post-operative and preoperative with that surgery. So when our colleagues in medicine complain, just point out to them that we're not just getting paid for the surgery, we're getting paid for routine perioperative care as well. The level 3 initial care, so when a patient first gets admitted, it could be a level 3 is a 99223, that's 3.5 RVUs. Subsequent care means the care for subsequent days, sometimes called sub-care, would be 2.4 RVUs. So how does this all end up adding up? Well, in most practices, about 8,000 RVUs would be the median, or the 50th percentile, if you will, expected. So you may or may not know that they're expecting you to do that. Typically these days, they tell you if you want to earn a bonus, you have to go over X number of RVUs. So 8,000 is about an approximate 50th percentile performance level. And then I broke it down into per month, per day, and just to give you an idea if you want to keep track. So this allows you to compare yourself to your partner, your friend, your cousin across the street, whatever person, and say, the work you're doing to see 10 patients a day on rounds that are fairly straightforward is less complicated than the work she's doing, seeing 10 patients with really big problems that take 2, 3, 4 times as long. Well, the RVUs should reflect that. If the documentation is good, then you can use higher value E&M codes to reflect that difference. So all of this has to be put into context when we talk about surgical procedures, because when you're paid for a surgical procedure, they're paying you not just for the operation, they're paying you for the work of perioperative care. So this is an idea that came from surgeons, where we said we should do pre-op and post-op care as part of our responsibility as surgeons. And this was adopted and became a national policy in 1992. And if you wanted to know what the RVUs were for a procedure and how long the global surgical package, as it's called, goes, you can look at that reference, but that's a detail. most operations that you do in the operating room, that we do in the operating room, have a 90-day global period. That means they paid you for that operation. And if you see the patient the next day in the hospital to adjust something, or they come back to your clinic to get their stitches out, you don't get paid anything extra for those extra activities because the operation was a 90-day global. So all the things you would normally do, you've been paid for already. Now, if that patient gets pneumonia in the hospital and you're treating it, great. All you'd have to do is remember, if you want to bill for taking care of a pneumonia or their diabetes, you have to drop a diagnosis that's different than the one you used for the operation. And since most of the bills, if not all, go to a computer, you have to tell the machine, please don't throw my bill out. Even though it's in the global period, I did something different than what you think I did. And the way you tell the computer that is by using something called a modifier, which is a little number that you see there that you put at the end of the A&M code. So it'll be 99233-24 or 57 or 25 or FT. And that's the only way you can get your bill to go through without being rejected by the computers is if you do something in the global period that's not normally being done, that's not routine perioperative care, just use a different diagnosis and make sure you add a modifier. So that's why modifiers are so important. If you've never seen the list of modifiers, look in the CPT book that the AMA sells you and go to Appendix A, and there'll be a whole bunch of these modifiers to look at. And again, when you take these courses or you read more extensively, you'll learn how to use them properly. One thing related to that, though, is if you remember when you first took the job that you now have, you signed a bunch of paper. And I'll confess that when I signed, I did not read every word. Somebody filled it out and put these little stickers so I could sign in the appropriate place. And they probably gave me what's called a specialty code or a taxonomy code sometimes. And they made sure that they picked probably my primary specialty code as 02, and my secondary code was probably critical care 81. Of course, there's no trauma specialty code because nobody thinks trauma is a specialty, right? Now, why is that important? Well, it's important because most of us practice in a team. We have colleagues that are on the same team that we're on, that are paid by the same entity, have the same tax ID, and I'll bet you have the same primary and secondary codes for specialty or taxonomy. So if I do an operation on Monday morning, and one of my partners sees that patient later that evening at 9 o'clock and does something for them, that activity is not eligible to be billed because it's in the global period, and that individual and I are considered the same person. Now, if that person does something that's not normally part of the perioperative care of the patient, they can bill for it, but they have to use a modifier. But please be aware that everybody in your group who has the same tax ID and who has the same specialty code is, for billing and coding and billing purposes, the same person. So if I do an activity in the morning and I see a patient on rounds and I drop a bill, a code for a bill, my partner comes along in the afternoon and sees the patient, they can't drop a second bill because the majority of the time there's only one E&M per day with the exception of critical care. So keep that in mind. This matters. Somebody needs to be tracking all of this, and I'm sure either your coders or somebody in your practice is tracking it. A special case mentioned, though, that always comes up and I think is worth a few more minutes of your time is the concept of documentation and coding for critical care services. So critical care rendered to critically ill or injured patients under specific conditions qualifies for a special code called a 99291 or a 99292. These are the only time-based codes in adult care. You may have seen numbers of minutes affiliated with certain E&M codes, but those are just general guidelines. This is a requirement. For you to get paid for doing critical care, you have to meet these requirements. It's important because this WRVU on this one, the work relative value unit, is 4.5. It's the highest E&M code. So this is the highest you're going to get without doing an operation. And by the way, we can't get into it too much, but if you do critical care for a patient you just operated on, you can bill for it. Because why? Because no operation is normally associated with ICU care. There's no such thing. And I'll show you why in just a second. But how do you decide if something meets a critical care definition? Well, Can't get into this in great detail, but I've developed this idea in my head that there are 4 specific items that determine critical care. And I've not borrowed, actually quoted exactly from the CMS manual, these 4 things. The first one is a clinical condition. So the patient has to be critically ill or injured, which is having one or more vital organ systems affected. So there's a probability of imminent or life-threatening deterioration. The second is you have to do something critical care-ish. In other words, you can't just say the patient was really sick, but I didn't do anything special. So you have to do high complexity decision-making that treats a single or multiple organ failure system and or prevents further life-threatening deterioration. So you can't get into it in great detail in a short session like this, but I can tell you if you follow these general guidelines, and these are direct quotes from the Medicare manual, you should be in good shape. The third criterion is it requires your full attention. You cannot be doing something else. You can't share this with other people for the time that you are going to quote. There are conditions in which you can do sharing with a mid-level provider, but for the moment, let's just say you have to do this yourself. And for that reason, I write my own critical care notes. Some people use the resident notes, but I strongly recommend that people write their own critical care notes to meet these 4 conditions. And the fourth is you have to say how much critical care time you spent, and you can't include time to put in a central line or an A line because those are separately paid for. So you should say something like X number of minutes excluding procedures. These are the 4 things I think about when I write a critical care note to make sure my documentation meets the standard. By the way, how do you figure it out? If you spend more than 30 minutes, you can bill a 99291. If you spend less than 30 minutes, it used to be you couldn't bill a 99291, but now you can if your partner comes and does the rest of the minutes that you need to get to 30. Then you can see how it goes. One thing leads to another, and you can accumulate more critical care time, but only one 99291 can be dropped for your practice on a particular calendar day. And then anybody else who does critical care will be added to your time. So the critical care clock starts at a second after midnight of a calendar day and goes on almost all the way to the next midnight. And everybody in your group who has the same tax ID and specialty code will add to that critical care time. So somebody has to go in and calculate it all. So there was an update recently that says that you don't have to get the 30 minutes by yourself, which used to be the way it used. You can do 20, your partner can do 15. Now you have 35, so you get that 99231. Finally, there's a little point to make here is that you may run into in your practice talking to the coders or the compliance folks who will tell you that, no, you can't do critical care on your patient, or you can't bill critical care after surgery because it's in the global period. That's really not correct. You can do critical care for patients you've operated on, and you probably should for many of them. And if anybody has a problem with that, this is the direct quote from the CMS manual. What's new recently is that now they've developed this new modifier called FT. So anybody who does critical care for a patient who has had surgery has to put FT after the E&M code, the 99291 or 99292. And that includes not just you and your partners who are considered one person, but if pulmonary medicine comes to consult on your patient, if that patient is a post-operative patient, they also have to do FT as a modifier. So this is really a part of CMS's attempt to understand how much critical care is being done and how to pay for it. This has been hopefully not too much information, and I do apologize if I went over time a little bit. I did prepare a list of potentially useful references that if you get copies of the slides, or I'm happy to share them with you if you'd like. And I realize this is a complicated subject, so I'll stand by at the end for questions. So to all of you who are transitioning to practice, or if you've been doing it for a while, wishing you smooth sailing. And that's my email up there. If anybody wants to reach out, needs the references, or has a question, I'm happy to help. Again, thank you for the opportunity to use up some of your valuable time, and thanks for the invitation, Avi.
Thank you, Dr. Fakhry. Appreciate your time and your expertise. And just so you're all aware, Dr. Fakhry has done a lot of work on the business side of medicine. He is by far absolutely an expert in this topic, and he was able to distill down a very complicated topic to really just sort of the A's and B's and C's and nuts and bolts. And as I said, the goal here is not to make you experts, but really to help you understand why it's worth your time to spend the time to learn about this stuff. Because, as he mentioned, it all comes down to getting credit for the work you're doing. And if you want to get credit for the work you're doing and that moves forward in your career, it really comes down to dollars and cents. It's really incumbent upon you to take the effort and time to do that. And like I said, we have some resources available there for you. We can send those links out to everybody. But just so you're aware that the ACS billing and coding course through KZA and then the TCAA basic and advanced finance courses, I would strongly recommend you take them at some point. Doesn't have to be during your training, can be after you finish, but I would highly advise you take those. And they'll go into a lot more depth about these kind of ins and outs, and it will really ultimately be in your best interest. This is a good way to segue into our next topic. Dr. Pat Murphy from MCW has done a lot of work in the area of what's an FTE. And for those of you who may not have heard of it, it's a full-time equivalent. It's essentially how do you define your job and your role. And it sounds like it should be a given topic or a slam dunk, but as Dr. Murphy will let you know, it's really not. And I think it's an important aspect for you guys to understand because of the problem about this not being defined very well throughout all of medicine, but particularly as it relates to our specialty in surgery and in trauma specifically. And it really relates down to, again, how much effort are you making? Are you being remunerated and compensated appropriately? And how are you being deployed in work? So he's done a lot of work on this prior to that, to this course. Actually, in fact, he's doing a lot of work outside of this. We just sort of came together as a result of this transition to practice course and some other efforts he's being made. So he's really truly an expert on this topic, and I think it's really important for you guys coming into training to understand this concept so that you can advocate for yourselves when you're looking for jobs.
Thanks for that glowing introduction, Abby. That's very kind of you. Yeah, topic near and dear to my heart, and have dedicated like the last 5 years of my life to, and continue to think about and explore a few conflicts of interest. Probably most importantly, that I realize this is a topic with many opinions and emotions, my own included. And really, the goal today is to try to bring some data to this question and encourage you to, I think, ask these questions of your future practice or your current practice and try to understand about why you work the way you do. Importantly, I am not going to tell you how much to work, very importantly. What this question is really getting at is how many surgeons do you need in your group to cover the clinical work that your group is tasked with covering? Seems like it should be an easy question. Many stakeholders, and today we're going to focus on, you all, me all, because the other part of this is we want high quality care delivered, but we also want happy, healthy, valued surgeons. Just a little bit about me. I'm Canadian. Everyone knows that about me because I tell them. And this is kind of my journey. And what got me into this was I went to look for a job, and you get these job postings. They're still up on many of the websites. You'll look for a job, and they don't really tell you how much you're going to work and why. Really frustrating as someone looking for a job. And I would even ask the people I'd interview with, like, no context of whether that's the right or wrong amount. I just want to know, like, does that match my expectations? Yes or no? Because that's really important to be happy in your job. Your expectations have to meet reality. This is a better example of a good one. Look at this. That's a full-time job in this practice. That's perfect. It doesn't really say how intense these are, how long they are, but a great start for, is that how much I want to work? And I might want to work more than that. What does that look like? Maybe that job's not right for me, etc. The other reason you should care is, our group of subspecialty surgeons, trauma and acute care surgeons, we're number one. We are the most burnt out of any medical subspecialty in the United States. And that's important beyond patient care, and our work directly relates to that. Normally, I talk about all the stakeholders. Today, we're going to focus on us and us alone. This is what I want in my practice. I want to help people. I want to be happy. I want to work where I want to work. Good culture, that's a big one. I want to be fairly compensated. I want to be competent. I want to think and do a good job and do good surgeries on patients. I don't want to think that if there was a different surgeon in my place, the patient would have had a better outcome. I still think that way sometimes. So we're going to try to narrow this substantially as it applies to those on this call. This is how work is traditionally defined in medicine. You take the number or amount of clinical work, and you divide by the number of surgeons, that's how much everyone's working. Makes it really easy. And if another surgeon leaves the group, everyone else just works more. Fantastic. Easy. There's a lot of nuance to describe how much clinical work is there to cover or how many surgeons you might be able to afford. This is a very blunt tool, and we're going to talk about how we might better define this. So the better way, I think, is, well, how many surgeons we need? And to know the answer to that question, you have to know this denominator. How much should a surgeon work? And how much clinical and non-clinical work you have. And importantly, I was asked to talk a little bit about non-clinical work and how that relates and how do I get protected time? What is protected time? And a lot of it comes back to the denominator here. What is 0.2 protected time if you don't know what a 1.0 is? You can't know what 0.2 is. It's impossible. In my practice currently, and I'll tell you a bit more about it, I know exactly what 0.2 is. And you can go on our schedule, print off the numbers, and someone who's 0.8 works exactly 80% as much as someone who's 1.0. And that's how we staff our division. And so there's lots of benefits to this approach. It does take a little more effort, I think. Needs buy-in from each other, administration. But it offers a ton of transparency regarding clinical and non-clinical expectations. We know when we have to hire more people. We can plan our workforce. And you just heard a ton about the work RVU. And we are continued to be and still will be measured by work RVUs. There are many drawbacks, particularly in our specialty. If you consider trauma, emergency general surgery, and surgical ICU in isolation, I have no control over the volume of patients I see in any of those specialties. So I virtually have no control over my work RVU production, and we can talk more about that at the end. It's a favorite quote of mine. You'll hear me say often, you can't manage what you don't measure. And in talking to many trauma centers, many don't know how much any of them work in terms of any metric, weeks per year, shifts, hours. And so that's the starting point. And I really encourage you, as you think about your job currently, or if you're going to go get a job, how much do you want to work? And think about why you answered the reason you answered. Because part of this is it's very personal and individualized, which makes it hard, but really try to be honest with yourself. So some lessons learned, and I'm going to try to bring some data to this. To be a successful surgeon, you have to understand this. And the reality is, everyone tells me if you've seen one trauma center, you've seen one trauma center. But we're all really similar. We cover similar groups of patients. We all are in resource-constrained environments. We have regulatory requirements. We want to work in good culture, and academic centers want to be academic. And we also have this in common, which I touched on at the start, is this is evidence-based. We're number one and continue to be by all metrics in 2025. So we need to consider how and why we work the way we do. So this is where we started. We just asked people, how much does everyone in your division work? And this is what we got. Um, this is not a reflection of how much you should work. This is just what people were doing back in 2021. We quickly learned that weeks of service is a bad way to describe our job, because I might say a week of service is 7 days. Abby might say it's 5 days. Someone else might say it's 4 nights. We need a common language, which we learned later on. But this was our starting point. 26 service weeks a year, 4 to 5 call a month, a mixture of elective practice. Don't know how to count that yet. And then, so he's kind of got like a snapshot of like what was happening around the country at what I think is a pretty representative sample of traumas. This is one of my favorite quotes. I love qualitative research now. I'll just let you read it. But basically, one surgeon defined a full-time job by just looking at the elective surgeons. Like how much do they work? And, I've really taken this to heart, that if you don't know how much you should work, go ask anesthesia. What do they think a full-time job is? Pulmonary care, 170 shifts a year. So even if you don't know around the country how much everyone works, look inward at your own institution. And then, I love this quote, we don't cost firefighters. My other favorite one is, you don't charge people at the hospital per elevator ride. If the elevator is unused, you still need an elevator. And that really describes our specialty. So then we asked early career surgeons not only how much they worked, but how much they wanted to work. This is kind of the takeaway from that study. You notice a discrepancy here. We're not going to get into the operating comment here, but this represents vacation. Because when I talk to people, I ask, okay, yeah, you work 2 weeks a month. Fantastic. What happens in February when you take a week vacation? I still work 2 weeks a month and do this exact same amount of call. And I'm like, so you don't have vacation? And they're like, no, I took a week off. It's like, no, you crammed 4 weeks of work into 3 weeks. That is not a vacation. Something to think about as you look for a job. Just briefly, I'm going to click through these just in the interest of time, but just to show this is our specialty in 2025. I'm going to go right to the end, the summary. Most people are working how they wanted to work less than they were, which, this basically represents vacation. And then a third were operating less than they wanted to. And we can talk about creative ways how you might think about that in your practice, like doing more emergency general surgery service when you first start, because there's more operative volume on that service. It's the way it works. So there are some creative ways to think about the drawbacks of a more standardized approach to a job. These are some quotes from, fellow early career surgeons, just highlighting we don't really know what we don't know. There's a lot of trust in our job of our leadership, good and bad. When I talk to surgeons who leave their first job, I've boiled it down to you either were lied to about what the job was, you lied to yourself about what you wanted out of a job, or what I think is more common is there's some Venn diagram of those two things. And that's okay. Particularly, like, you might not know what you want until you go work it for a year, and it's okay. But just something to think about, trying to really be honest with yourself early on. This is the Are We Weak section. This is mostly from Dr. Jamie Coleman, and she did a great study and continues to do great work here. And the references are more if you're just interested, and I'm just going to get to the recommendations. Even without working less volume time, there are ways to arrange financial incentives and scheduling that still make our lives better. For instance, you don't have to do Q2 call and then have 2 weeks of no call. You might choose to, but that does not overline with human physiology in any meaningful way. something to consider. Don't incentivize bad behavior post-call work, and be intentional with the schedule and understand where the group's at. And, you can, I think, engage with people even if you are a junior and new faculty. Like, this is important to us all, and I think there's ways to engage in any structure. And it doesn't matter if you do home call, like some of us do home call for whatever reason, if they're like level 3 or some level 2s if you live close. So call is call. Okay, what you've all been waiting for. How much should I work? This is my opinion with some data behind it. So I basically arrived at a definition two ways. The first is, uh, you know, this is what I like, the language shifts, because everyone knows what that is. It's not weeks. Particularly because the C-suite understands what a shift is, which is really important as you try to advocate for this stuff. You multiply by 12, take some vacation days off, 204 shifts a year, fantastic. You could get to a similar number just thinking what, normal people work, normal elective surgeons. Many ways to look at it. They all kind of arrive at the same number-ish. I frame this, however, I think administration is going to receive it better in general. And then, most recently, and this is recently accepted, hopefully published soon, we applied this definition across the country, 204 shifts a year. And turns out, and not news to probably anyone on this call, we're very short-staffed if you apply a pretty standard definition. And now the question is, what do we do with this? But we're like really short-staffed. And even the ones who are, quote unquote, well-staffed, they lose one person, they can't cover a call schedule. We don't have built-in redundancy like other industries. Something to think about. On the redundancy, like if you go look at who should I compare us to? Let's compare us to McDonald's. Pretend trauma surgeons work at McDonald's. McDonald's staffs for redundancy because they know there's a certain amount of, you can't work 100% of the time. And so there's redundancy built in. And we've traditionally not done that. And lots of reasons why. The work RVU is one of them. But something to think about, like what happens when a colleague of mine goes off on medical leave or wants to start a family and takes maternity leave. Like, what happens to our practice then? As a brief aside, and something that I also consider thinking about as you ponder this information, I talk a lot about shifts, but not all shifts are created equal. And we should also consider intensity of work. And this is some unpublished work soon to be published, I hope, where we look at how many patients we should take care of on our service lines. And it's probably less than your service line currently runs at, if I'm guessing. Okay. Non-clinical work, very important to consider. I know Dr. Bonnie's on the call, and I'm going to steal something from her. Maybe she has this in her talk. Unpaid work is a hobby. Don't make call your hobby. Don't make non-clinical work your hobby. This is why understanding what a full-time job is really important. Even if it's just local, because then you're very clear on expectations. I hope I didn't steal your thunder there, Dr. Bonnie. This gets back to protected time. I can give you what I think all these jobs require to do well. But usually it's dictated by the hospital. So you want to look at these before you commit, understand what a full-time or what protected time is. Like a K award for a surgeon is 0.5. That should mean you work half as much as a full-time person. If you're not, you don't have protected time. This is just an example, and I do want to be mindful of time, so I'm going to move through it. But this is my hospital. This is our group. How many shifts we have, is how much work we want to cover as a group. Very countable, knowable. You can do this. That's how many it is. Cool. That's a full-time job. We need 14 FTEs, not 14 surgeons. 14 FTEs. This is our breakdown. This is like everyone's got another job basically. And we only had 10 FTEs. So we hired more, and we did. But this is like a more rational approach to staffing a division. Right, talked about that. I've been criticized a bit about when I talk about this, and I think rightly so. But what's the other side of this? Okay, you want to work less, maybe. What about competency, coverage model, payment? What about redundancy? I think all really important things to consider, particularly the competency one. And I've tried to ask this question to people like, say you get a K award. What's the minimum amount you can work clinically as a faculty 0 to 5 years and still be competent? Like your partners trust you to be able to get the job done in a similar way they would. I don't know the answer to that question, but it is worth considering as you kind of think about other non-clinical work that's really important to you, how that affects your clinical job. This is the takeaway slide. This is how I define a full-time job. And I put a range here because you need to consider intensity, density, and time of the work. To me, that's local considerations. These are kind of guardrails of what I consider norms. I've seen some practices are at the bottom end, 180. Of note, Palm Creek Care, 169. So it's for some context. And, if you have a lot of home call that's not busy, probably the upper end of this is more reasonable in terms of the finances and, coverage model of your practice. You want to count for call. Unpaid call is a hobby. And, this all boils down, I think, to leadership in your division. And your leadership, or if you are a leader, is so important for all of this. And I really empower you to think about this as you're looking for jobs in your current job. Some takeaways: really try to be honest with yourself. This can be done. I know it because I live it. So please think about it and try. It's hard, but this is how we're going to transform, I think, our specialty into a real sustainable model that residents are going to want to go into. I obviously didn't do really any of this alone. And there's fantastic groups of people in our specialty who have really opened their doors to myself and others to let us be introspective. And I think we'll do questions at the end. Thank you for your time. Appreciate talking here.
Thank you, Pat. I'll just tell all of you, listening to that, because that's the first time, Pat and I have talked about this a lot informally. I've never actually heard his presentation. I wish I had heard this 10 years ago, 13 years ago when I was in training. This stuff is so, so very important, and it will help you guys more than you will realize if you keep some of these things in mind when you're approaching your job searches. There's no right answer to a number, but recognizing that there should be something defined and asking yourself really wholly to yourself, what do you want? What's going to make you happy, and focusing that attention, but having some place to where to start. This is incredible. So recognize that this is important. Not everybody realizes it, but they will by teaching you guys about this stuff. And when you go out there and start interviewing and asking these questions, we will force the issue. It's not going to happen quickly, but it will come because enough of you guys are going to go out there asking these questions and not taking the jobs where it's not defined, that we will make change. It's just going to take time. So if anything, I would say this is actually probably the most important talk of this entire session, is understanding this point, because your value and your worth should be defined by you. And what's okay for you may not be what's okay for somebody else. But if it's not defined at all, you will get taken advantage of. I promise you that.
Can I ask a question?
All right. Yeah, go ahead.
I'm Nora. Can you set up a hotline for, is this what I'm actually getting? Help me.
We'll get to that. Part of this is going to be ongoing feedback. I promise you we will have resources for that. Because I know that this was coming. Because these are the things that will come up as we talked about this. So I'll address it. But just in the interest of time, we're going to move forward. The next sort of group of things should go relatively quickly. We're just sort of talking about practice types. This is really just not going to get into a lot of details, but just to give you guys a concept, generally speaking, as to what jobs are out there, more than just, oh, I'm going to go to work to University X. We'll talk about that too, but it's sort of a smorgasbord of practice opportunities. And first up is going to be Dr. Salina Wydo, who's going to talk about sort of the traditional academic model, which most of you already know, so you don't need to hear a lot from her, but she's well versed on this topic, having been your entire career right in academics. She's also a program director for the Critical Care Fellowship and is very well versed on this topic.
So far, first of all, thank you. And I totally wholeheartedly agree with everything that Avi said so far. Trying to give you guys the information to make the best decisions for yourself are really the goals here. I don't want to say anything that's too reductive or take up too much of your time. But kind of the big things about academic practice I want you to keep in mind as you're going into first jobs, second jobs, etc., is that the academic world has so many extra expectations of you than even in private practice, community practice. I think that's kind of going to be a big theme of this whole section is what are the pros and cons? What are you going to get that makes you happy? But what are the unspoken or sometimes spoken, but what are the extra demands that you're going to find like put on you in addition to your clinical practice? So a lot of this was also mentioned by Dr. Murphy when he's talking about FTE and knowing your worth, knowing how much you're supposed to be working, and not doing things for free lest they become your hobbies. But in academic practice, one of the things that I really like, and I think that there's a lot of pros to, is there is so many opportunities for growth, for advancement, and being able to explore a lot of other facets of interests. Some of the things that people branch off into are like the pillars of academic medicine beyond clinical care would be education, particularly educating trainees, fellows, residents, medical students. Some of these practices and some of these sort of settings will actually have a minimum amount of lectures you have to give per year, a minimum amount of hours of service to the medical school. So if you're considering a practice in academics, asking these things up front, what are the expectations of me when it comes to teaching and being responsible for the education of others? You know, what are those expectations? Are there actually things written down, certain metrics I have to meet? Or is it more broad-based, more nebulous as long as I provide service to the medical school? Another pillar of academic medicine would be the research component. People who love research tend to know they love research, and people who don't love research also tend to know they don't love research. And there are those of us who are somewhere in between and do the projects that, call strongly to us, ones that we do out of, sort of obligation to profession, ones we feel sort of morally responsible to contribute to, but frequently you've got people who love it or hate it. It's important to have a set of skills that allow you to participate as necessary. But if you're going to an academic job, one of the things that's incredibly important is knowing exactly what you're going to have to do publication requirement wise. Some academic hospitals have really sort of embraced there are different pillars. There's clinical medicine, there's education, there's research, there's service to the profession. And as long as you're serving in some way, shape, or form, we consider this academics. There are some that still have a kind of the more traditional understanding of what the academic medicine, the academic surgeon would be, which would be requiring some surgeon scientist participation. And some may actually have quotas you have to meet for publications. One of the things to keep in mind is in the academic world, you're going to have an appointment at the medical school or whatever your associated institution is. They're going to expect you to apply for that and then to continue along an advancement pathway up the realm, up into a professorship. Totally beyond the scope here to talk about the different tracks, sort of how to do that. But you also have to remember, if you want to progress in academic promotion, there will be a certain amount of things you have to do, publish, lectures you have to give, hours to serve, etc. And it's always helpful to ask about those things when you're getting involved early on in these jobs. And then service to the profession. So another pillar of academics, one that I don't think gets talked about a whole lot, would be service to the profession. Ways that people can also contribute to sort of to their academic portfolio, to the institution, would be volunteering for committees, not just at the local hospital, but particularly in your specialty on a regional or national level. So service to the profession as in membership in EAST, being involved in EAST committees, being involved in PMGs, being involved in any of the amazing products that EAST has to put out. Thanks, Avi, for this one, by the way. Or the leadership development course, or I honestly, I could spend probably about a half an hour just ranting about how wonderful all the different products are. But participating in and giving back by doing those things is also another very important way to contribute to an academic career and academic a job. Sometimes jobs will also the academic jobs will also monetize these contributions. You may pay for publication, you may pay for service, pay for lecture, etc. And these are all things that every hospital is so different, every job is so different, so individual, that it's going to be extremely important to ask the specifics where you want to be or where you think you're going, because just because you've seen one setting or two settings or three settings means you've seen three. It does not mean you've seen more than that. Everything is totally individual. When it comes to pros and cons of an academic practice or an academic job, again, this is all going to be depending on who you are, what you love, and what you look at. But probably the most commonly cited things of why people love the academic environment is going to be opportunities to do all of these extra stuff. I love clinical care. I do. It's probably still my favorite thing. But when that gets tiring, and when it gets frustrating because you spent an entire week in the TICU with difficult situations or difficult families, or people fighting with you, sometimes it's nice to take a step back and be like, okay, the thing I really got from this week actually was I helped the intern put in their first central line, and that was they think the best thing that happened to them this past month, and getting to contribute to that and knowing they're going to be able to do it next time. So being able to contribute to the next generation teaching, lots of people love that. At the academic hospital where I am, one of the things that I've gotten to branch out into that's been very, very personally satisfying, and I'm trying very hard to not let it become a hobby. I'm sort of losing the battle, but I'll have to talk to Dr. Bonne about that later. I got involved with the bioethics department very early on in my time here, and have really loved getting to participate in helping navigate these issues, being a consultant for the hospital, and recently became vice chair of the ethics committee. And this is something that I wouldn't necessarily have had. I would have never realized I loved had I not been in a place that had that as an option for me, and having good mentors, having my boss sort of say, you seem to be really well suited for this, and I think you would enjoy it. Would you consider trying it? And it did end up becoming something that I really love. So perks of academics, being able to branch out into these things that you may not have had exposure to elsewhere or in different times in your life, things that you may not have even realized were options for you. Cons, one of the big cons, and again, this is a generality, this is not a reality for everyone, but the university-based jobs tend to not reimburse as well as private practice does. Again, stereotype and a generality, it may not apply to everyone, but again, you're going to have to ask a lot of good questions when you're going into practice. Most people in an academic job are hospital-based and hospital employed. Very few of them are actually self-employed. We are all, the hospital pays my paycheck. The hospital provides my malpractice insurance. The hospital gives me benefits. And not having to worry about any of those things is actually for me a pro. But for some people, the fact that they may be able to make elsewhere in a non-academic setting would be a con for them. Other cons, again, it really depends on who you are. If you're okay with the pressure of knowing I have certain quotas to meet, I have certain lectures I have to give, I think that it's a good setting. It just all depends on what you want. The other thing is don't let don't let it become a hobby. Very much echo that. I don't think that could possibly be said enough. And a huge con to academics, which love it, but also con. There's so much potential for growth here, but the more you do, the more you get asked to do. And it's a really big challenge learning what you can say no to and what you should say no to and what you can't say no to. And that I think takes a lot of mentorship and a lot of self-awareness to navigate. So thanks for letting me rant. Again, I don't want to be reductive, nor do I want to repeat a lot of the things that have already been said, but I'm happy to take questions at the end or help you however you need.
Thank you, Dr. Wydo. I'll kind of go quickly to just in the interest of time. This section kind of falls under the umbrella of academics, but in case you guys don't realize, academics does not necessarily equal university, right? There's traditional academic university settings, but you also have hybrid community-based programs that have GME programs, but it's sort of a hybrid between the private practice model and academic or traditionally academic university-based. Typically hospital-employed positions. Oftentimes it's a mix of for-profit or not-for-profit institutions, but I will tell you is that moniker doesn't really mean anything. At the end of the day, they all function like for-profits because they're all there to make money. So keep that in mind. I'm not going to get into a lot of details. As Dr. Wydo mentioned, positives or negatives really kind of reflects what is important to you. And so what may be a positive for some person may not be a positive for you. This is sort of taking the lens of the generalities of what people sort of perceive the positives and negatives to be. But at the end of the day, this will really come down to your specific individual needs and desires. But, typically with, let's say, the hybrid community practice, generally there is teaching. So that's one of the reasons most people go into these types of jobs, but there's less burden in terms of traditional university-based program, in terms of the effort that you have to make, in terms of extra lectures, things like that. The distribution of your teaching, I think also that's another thing I never realized at your guys' level is, teaching to a student versus teaching to a resident versus teaching to a fellow is very different types of teaching and educational experiences. And so oftentimes you'll have residents, you will plus minus students, not oftentimes have fellows, but some community programs will. So just keep that in mind. And talking to what Dr. Wydo mentioned and Dr. Murphy mentioned about the administrative burden, because that is one of the big drawbacks with university programs is a significant administrative burden in terms of the extra things, the hobbies that you're supposed to be doing or expected to do. Generally speaking, less administrative burden with these types of jobs. Research recitations typically will be there because they are still GME programs, but less so than traditional university-based programs. Oftentimes, usually the big draw for these is, I get to teach a little bit, but you have more freedom, more flexibility. So really your free time is really more your free time than a typical university-based job. That's probably the big draw to these jobs if you like teaching but don't want that extra burden. And again, as Dr. Wydo mentioned, typically, again, generally speaking, money tends to be better in these jobs. Every situation is different. Benefits are oftentimes better, but that's also very job specific. So just keep that. This is very much just a generality. Again, negatives, it's just how you perceive them to be. It's not a traditional academic path, fewer opportunities for career growth. Like Dr. Wydo mentioned, some of those extra things that you wouldn't have otherwise been exposed to. Whether that's a positive or negative really depends on your priorities and what you want. But from a traditional perspective, your opportunities for career growth are less. However, also, as she mentioned, you can get involved in other organizations outside of your primary institution, working through EAST, AAST, these other organizations still give you opportunities for career growth from the traditional lens, though maybe not so much of that opportunity. Generally speaking, less engagement with trainees. If you want to be very involved and want to be very hands-on, less of an opportunity in the hybrid program setting, but that's really kind of what you want to make of it. And I'll say this is just my personal experience. Really, you're just another employee, right? There's no loyalty. Just keep that in mind. You may think that's the case. That may sell you a great story at the front end, but at the end of the day, to the institution, you're really just an employee, just like everybody else. So go into that with those eyes open and having minimal expectations about, long-term career goals and loyalty to you as a physician really does not exist in this healthcare infrastructure in 2025. So moving forward, I'll kind of end that part. We're going to transition into Dr. Bonne. He's going to talk about sort of the private practice environment. And Dr. DiNitto is going to talk a little bit about locums as an opportunity, since I know that's generally speaking not something you guys ever get exposed to or hear about, but it is absolutely something you should know about as a career.
Thanks. So I think I'm like essentially pretty much redundant to what you just said, which is I'm going to talk a little bit about ACA community, and I'm going to talk about community practice. I'll follow up on a couple of things. First of all, I don't want people to think that unpaid work is just hobbies. There is unpaid work that you do because it's setting you up for success in other spaces. So, for example, like if you are, you know, doing a bunch of like resident lectures because you want to build your academic portfolio so that when the, next APD or PD position comes open, so there's like a balance there. But I do think that, traditionally, particularly trauma surgeons, because of the nature of our practice, because we're so hospital based, we do tend to get taken advantage of for some of this sort of non-clinical work. It's kind of like how, whoever the woman is in the division is always the person who brings cupcakes for people's birthdays. It's like you just want to make sure that you don't become that person that's like the, constantly the cupcake bringer. I am trying very hard to share my screen and get to my slides here. Let's see if so. I don't really have, this is not like crazy, but I'm really going to talk mostly about contracts. Can you guys see my slides? I know I'm not doing slide mode. Okay, whatever. So things to address in your contract. So if you have a hospital employee contract, so remember what a contract is at its base. So it is, what are they agreeing to and what are you agreeing to in return? So it is a negotiation, it is a relationship. So your agreements are going to be things like how much time am I going to work? And Pat gave a great talk about, time and figuring out how much time is fair for how much money are you going to be paid. And so there are a lot of potential models for that. I'll go into a couple of them. It may be time-based, so like time worked, like I'm going to do X number of shifts, or it may be work-based, like I'm going to do this many RVUs, or some combination of those. Then the expectations, there's a lot of boilerplate contracts around there. And people often say like, do you get a lawyer involved in your contract negotiations? So I'm fortunate to be married to a lawyer. So for like the boilerplate simple contracts that happened earlier in my career, I just had him look them over or had a friend or whatever. Because they from these like large organizations, these large healthcare groups, and hospital employed, these are largely going to be very boilerplate contracts, and they're going to outline things like you need to maintain your certification, you need to provide good behavior, you need to participate in the medical staff, and they are going to provide administrative support, this amount of CME, this is going to be your vacation and benefits, and here's how you're going to be paid. The other thing that is going to be addressed in your contract is what happens when you leave. So there's going to be whole sections of your contract that have to do with severance. And this is really, really important. So you're going to want to look at what is your non-compete. Be very careful about your non-compete. And there's all this like, oh, the FCC said non-competes are not enforceable. They are still being enforced. That's a lot of that's getting clawed back. So be very careful in your first contracts about what your non-competes are. My first contract was in St. Louis and I had to leave St. Louis. Like I had a 50-mile non-compete as a trauma surgeon. There's nowhere else I could go. Your tail malpractice coverage is going to be very important because you want to make sure that your malpractice is incident based so that like if you get sued for a case that you did on the last day that you're employed, that your malpractice doesn't get dropped the day after you're employed and now you're on your own to cover the malpractice of that case. Notification time. So this can get real dicey too. Like, do you have to give them 3 months notice? Do you have to give them 6 months notice? Some contracts I've seen have like wild, like 9 month, 1 year. So it's like you're moving, your partner gets a job in another city and you decide that you're going to move 3 months from now and you want to go work in that other city, but you still owe them a year. And like, now what? You're flying back, so like you need to like, and these are often negotiable points. And then your contract renewal period. So when are you going to renegotiate your contract? Is it 1 year? Is it 3 years? Many places have a 1 year, you're kind of married to each other. You cannot leave without cause, and they cannot fire you or let you go without cause. And what cause means is like some sort of egregious thing, like you're openly sexually harassed by your boss and you want to leave, that's cause. And those are often accompanied by what's called a cure period. That's like 30 days. So say that, you're you get sexually harassed by your boss and you want to leave. They have 30 days to quote cure the situation, which could mean firing your boss. And then you're still stuck in your contract and you can't leave. So those are some things to, be aware of. In private practice, often what you're going to start out your first contract is going to be very similar to a hospital employed contract, except that you're going to be employed by the partners of your private practice. You're going to have similar expectations. You maintain hospital privileges. They're going to pay you X amount of dollars to take this amount of call. And so you want to look that over. While hospital contracts can be very boilerplate, I would suggest lawyers to look at private practice contracts because there may be things that an employment attorney can help you if you're going to work for even a large private practice. Like how are they covering your benefits? How are they supporting your CME, your vacation? And most importantly, how are decisions made about the practice? And do you have a say in them, or do you not have a say in them until you become a partner? And then severance, what does severance from that practice look like? So what most people didn't realize about in training, when you join a private practice, you're typically going to be an employee of them for something like 3 years, and then you may be offered a buy-in, and you can write that in that like after 3 years, if I meet this metric and generate this many RVUs or whatever, that I have an option to buy into the practice. And that means that you become a partner. If you never become a partner, you're just a forever employee of the practice, the same way you could be a forever employee of the hospital. But you don't just like after 3 years get like a gold star and become partner. You have to buy in, right? That practice has value. It has a reputation in its community. It has the tables that they've bought to sit in their exam rooms and their the computers that sit at the front desks of their office space. Like those are all assets of the practice. And so you don't get to like get 1/4 of those for free because you just became the fourth partner. You have to buy in. And so typically those buy-ins can be, anywhere from $500,000 to $1 million. And you're like, well, who am I going to get $500,000 from? I'm paying my student loans. I just, whatever. So typically there will be a buy-in, and then you're essentially going to take a loan against your time. And so having that outlined as well too, like, do you have to go out and get a professional loan and put up collateral to pay your $500,000 to now become a partner? Or do you now get paid like a partner, and then they're going to dock your pay every year for, your partner level pay every year for 5 years until you've paid your buy-in. So those are some of the typical contract type negotiations. And so because that gets very complicated, that's where a lawyer can be really helpful. I'm gonna blow through these, but here's some things that you should make sure that you have in detail. How long is a shift? How many shifts are you working? How often is this audited? Is your call home or in-house? What is the RVU rate that you're being paid at? How does that compare to the MGMA benchmarking in your local area, which is a document that benchmarks RVUs and how much people get paid in your region. Straight salary models, like you get paid and you show up for this many days of work. That's it. You might have some sort of discretionary profit sharing bonus. RVUs may or may not be calculated or tracked, but it doesn't really matter. Salary plus RVUs, you're going to get a base. The base is like, we're going to pay you $300,000 a year to provide, X amount, 100 nights a year of trauma coverage, or 124-hour periods of trauma coverage for the year. And we're going to pay you, $50 per RVU that you generate when you're on call. So that's what a salary plus RVU model would be. You will frequently get a lower RVU rate for trauma because you're being paid for your time to sit you're paying for your time to sit in the call room and watch Netflix, and then you're paying for the RVUs for the trauma patient that comes in on your shift. You may get a higher RVU comp rate for general surgery if there's no base call coverage associated for general surgery or for emergency surgery. So like in my institution, for example, we get paid $16 per RVU for trauma, and we get paid $57 per RVU for general surgery. And that's because there is no call pay for general surgery. It's just you take call in the hopes that some general surgery case is going to come in and you're going to be able to generate RVUs off of that. I'm going to blow through some of this again. Time-based specialties, that's us. You pay for us to be there. So I encourage people to have something where your time is being compensated, not just a straight RVU model. Straight RVU models kind of screw trauma surgeons because unless you're going outside of the hospital, driving around the parking lot and hitting people, you have no real way of like drumming up business. Private surgeons, general surgeons, even employed general surgeons can drum up business, right? They can go to the private practice physicians. They can show that they have good outcomes. They can develop relationships. They can, say like, hey, I'm here to fix every hernia that comes into your primary care physician's office. We can't do that as trauma surgeons. I'm going to skip through this. This is some of Pat's stuff. What do you do during your time? We hear this all the time as trauma surgeons. What do you do during your time off? They think that we're like doing this when in fact we're doing this, catching up on all of the tasks of our lives. If I had $1 for every time I heard somebody say like, what do you do during your week off? And I'm like, I don't have a week off if I just worked 100 hours in the ICU last week, right? Like your Saturday is my Tuesday. So that's not time off. And so in getting people to understand that, even like former trauma surgeons who are now chairs, is breathtakingly difficult. So private practice, like I mentioned, until you're a partner, you're basically an employee. You need to outline the appropriate steps to partnership. That's going to be the big thing. I just want to highlight, beware of becoming the third partner in a practice that has existed as two partners for a very long time, because you're always going to be the third wheel. Because they have a relationship. So when it comes to making decisions about the practice, and there can be big decisions. We want to fire our nurse. We want to stop covering general surgery call at hospital X. These are big decisions. And if you're always the third person, your vote doesn't really count. And be extremely careful of joining family-run practices, like father and son general surgeons now hiring you to come help out because their practice is very busy. That's very dangerous because it's, family. Solo practice. I'm just going to say that I don't really recommend this. I spend a lot of time, like Dr. Fakhry, on business and finance, and my new role, and I'm new in a role in a healthcare system where like I'm looking at all of the finance across all of the trauma centers. I don't see how it would be possible to be a trauma surgeon in solo practice in 2025. I cannot make the finances work. We can talk a lot about RVUs and generation and things like that, but the fact is that physicians don't really make money. Hospitals make money. And so the reason that hospitals hire us to staff their trauma centers is because they're making money on the hospitalization, not because they're making money on our professional fees. And this is why. So Medicare fees are not keeping up with the inflation. It's extremely hard to make a practice viable on physician fees alone. Here's just more of those same depressing graphs. Things you can put into your contract, one-time payments, relocation, student loan repayment, sign-on bonuses. They love this. If they're going to give you something, they would much rather give you a one-time sign-on bonus or some student loan repayment than give you an increase in salary. And the reason is because your benefits are often tied to the amount of salary that you're making. And so that's like a forever cost for them versus the one-time payment. So a lot of times you have some leverage to be like, no, I'm going to need a little more signing bonus. You may, if they see you as a future leader, particularly in academics, you might be able to negotiate things in like professional development courses, advanced degrees, board review courses if you haven't passed your boards yet. So you want them to pay for you to take, the Osler course or whatever. And then potentially additional required or optional certifications. So, neurocritical care, they need an extra intensivist in their neuro ICU. Hey, I can do that. Why don't you pay for me to take a class and take my neurocritical care boards? always consider your tax implications. So relocation and sign-on bonuses are taxed. So if you get a $10,000 sign-on bonus, it's really only $5,000. And you got to be real careful, especially as you're coming out of residency, because your tax bracket is going to change. And so your taxable income is going to change, and you need to be very careful there. But direct payments sometimes are not taxed. So like, hey, instead of taking this $10,000 sign-on bonus, why don't you give me $10,000 of student loan repayment? That's a better deal for you, and it makes no difference to them. Please pay attention to your vesting schedules when you're looking at your benefits. There are some places where your retirement will not vest for 3 years. So you're putting all this money into your 401k, blah, 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 or they're match. So you're putting all this money in, they're matching it, but their match doesn't vest until you've been employed for 3 years. So if you leave before that 3-year period, all of your match goes away, which can be 6 figures of retirement. If you want to tax defer your savings, you have lots of options. You have traditional 401k, you have both Roth and pre-tax options, 457 plans, and these golden handcuffs of these vesting plans. And then you can also get golden handcuffs in the academic institutions later on when they tell you that they're going to pay for your kids' college education. And now you've got, if you're like a little bit further on and you have like a 14-year-old, that's a real big deal. So pay attention to things like that too. Disability is often not ONOC, so you want to make sure that you get your own occupational disability. Like if I can't be a surgeon, I get disability payments. Many of the disabilities that you're going to be offered through hospitals and employers is going to be if I can't be a doctor. But if you could practice anything else in medicine, like say you break your hand gets cut off, well, you can still be a radiologist. So you're not going to get disability for the disability that your hospital provides. You want to pay attention to your life insurance, your health and dental, and then your HSA and FSA plans and whether or not they have things like that. And then we talked about leaving for cause, not for cause, and cure clauses, notice time, and then your contract renewal period. I just like to put this up. What does locums make? Which is going to drive us right into our locums. And then this is what they made in my last institution. This is what we paid them. So, you can, decide whether or not it's worth it for you. And then here's an example of an MGMA table. I encourage you guys to look at these. This is an old one, but find this and it'll go in your region of the country. What is the average RVUs and median income for physicians in your specialty? There is a different one that the AMA, the medical school one
double AMC
organization puts out. Yeah, for academic practices, because it is very different. And it's a little bit about this is in the interest of time, we'll just go away from those. But thank you for your attention. I am really happy to be available. I know a lot about this. I've talked a lot about this. So please email me if there's any questions.
Thank you, Dr. Bonnie. I'll have Dr. DiNitto talk a little bit about the locums option. Again, there's not a lot to talk about, but I think it's important we discuss it so you guys know it is a viable option for your careers because it's not really ever talked about during training paradigms and training models. It's important, I think, that you guys hear about it to see if it's a good option for you. So I'll let her.
So as far as locums goes, I started out as working in a level 1 trauma center and basically worked there for 3 years. And in the interim, when I was going to look for another position, wasn't really sure kind of, the things that were talked about today, what exactly where I wanted to go, whether it was purely going to be more academic or community. So I started doing locums, and now it's been about 3.5 years. So I'll go through these quick. And if you're interested in doing locums, give me a call. A little bit about how it works. So we start with, obviously they'll call. And if you think that they won't call, I'll just talk and you won't see me. But if you think that they'll start calling you, from different companies and things like that. And they will ask you about your availability, about your board certifications, and also about where your licensing are and whether you're interested in licensing. So from there, if you tell them you're interested, they will then kind of put a little file and then we'll reach out to you when they have a need. That need can either be urgent or something like much later in the year, just depending on how people are scheduling and things like that. From that point, when they ask you about a need in a specific place, they'll also give you a rate and ask you if you want to be presented. And this is probably the biggest caveat that I will say that I learned the hard way, is that once you tell someone it's okay to present you, they basically own you for that facility for 1 to 2 years. And that includes whether you want to apply there for an actual position. So they could potentially be on the hook. And again, everything is a negotiation, but you just want to be careful saying yes to someone about the ability for them to present you unless you're sure that you want to work with them. They may not have the best rate and things like that. Then they present you to the facility, and the facility goes through your CV, which you've sent them, and they basically decide whether or not you are a fit for them. Sometimes there's an interview, sometimes there's not. And if there's an interview, then you see if it's a good fit. Some questions to ask are, especially in our profession, whether or not you feel comfortable doing scopes. General surgery, a lot of the locums positions are a lot of like outpatient scope positions. So if you're not comfortable, you can tell them you're comfortable with general surgery, but not scopes, or you just want to do trauma, or you just want to do critical care, or a little bit of both. Something that I found out the hard way is you want to ask, who will be your support staff while you're there? Will you have a PA or a first assist or residents in the operating room? And keeping in mind that all residents are not the same wherever they are. As we all know, and we've all been residents, but some newer programs don't have a lot of senior supervision, and they're just different. And then obviously, once you decide and accept the job, as well as everything else, then you have to get credentialed both through the locums agency as well as through the hospital. So it's a pretty timely process. If there's an emergent need, sometimes they're able to do it quickly. Some states you're able to get a license in about 3 weeks. And other states, like Massachusetts, it could take 9 or 10 months. So that's kind of all, and the locums company does all of the paperwork. They will absorb the fees if you've agreed to a particular job with them, but they don't always reimburse it till after. You need to make sure that you have some case logs to be able to provide people, and then I'm going to keep this short because obviously this baby is not really excited about, but some things to keep in mind. It is 1099, so you're not a W-2, so you're a contract, so you are not getting any taxes withheld from your paycheck. So if you got paid $200 or $300 an hour, you get $300 an hour on that paycheck. But the IRS is waiting, and you need to be able to put money aside as well as make quarterly payments. With that being said, a lot of people think automatically you want to set up an LLC or a C or an S Corp. However, it depends on how much money you're making, because those also have tax implications, which sometimes can help you, but sometimes the taxing, the payments that you make to the accountants are actually more money than you're saving by doing it. So it's really important. And if you're thinking about it, give me a call and I can give you some help and some suggestions for that. And then obviously health insurance, you'll only be able to go through like an exchange. I have found a union that you can join of other people who are 1099 to get more of an employment type based health insurance, which has been huge. It's very expensive, very costly, but it's good insurance. And as you can see, I have a baby, so that's important. He's a little monster. So retirement also, again, there's no matching. There are no plans for you coming out of that paycheck. Everything is really on you. So, having that accountant plus or minus a financial planner or a little bit of education on your own. There's some great Facebook groups and things like that can help you with that. Obviously, savings for some taxes and things. Your expenses. You are able to deduct a lot of things. I thought you could deduct way more than you could. I also, my first year, didn't realize I needed to pay self-employment tax, which was a hefty, hefty fee come April. That again, if you kind of are thinking about doing this, just that quick talk with an accountant is really worth it. And then malpractice, they will cover your malpractice. However, each company has a different program. So some you may need a tail coverage. So you want to make sure that they're providing that for you, or you need to get it by yourself, which is fine. But you want to also know if it's an occurrence-based. So if you're working with multiple locums companies, you'll need to know which type of malpractice each one has. And then licensing by each state. Every state has their own license requirements. Some are heftier than others. They can get pretty costly. For example, I got my license in Florida for a so-called urgent need, and I never ended up working in Florida. And now after 3 years, I did not renew my Florida license, but I now have to disclose that I didn't renew my Florida license because they required a lot of CME, and I haven't worked in the state, but just things like that to keep in mind. So again, that was very quick, and I apologize for the baby in the background. Obviously, one of the positives are you have some time to be able to spend at home. And, it did renew my faith and my joy in what I do after my first job, which I obviously didn't, choose the right job for me. There are some negatives associated with it too. And you do sort of end up missing a lot of the monotony of things. However, again, if it's something that you're interested in, please just reach out to me and I'll be happy to help.
Thank you very much, Sarah. I appreciate you taking the time, especially given everything that happened with the kid and the baby. But a lot of relevant information. There's a lot of other detailed stuff we can certainly help fill in later on, either Dr. DiNitto or myself. I've done a little locums work, not nearly as much as she has, but if you guys have questions about that, we certainly can help address that offline. Just in the interest of time, I know we're over. I'm going to go real quick to this last one. If you ever find yourself in a situation or a position where you feel like it's just not, clinical medicine is just not for you anymore, the take home is that it's okay. You have options. I'm not saying you're going to get to this point, but if you do, it's not like the end of the world, whether it's in your training, whether it's a year out, whether you're 3 years out. If you get to that point, don't feel like it's the end of the earth or the end of the world, because you do have options. Just to go quickly, I'm not going to go into a lot of detail, but this is things like medical consulting, medical writing. A big thing nowadays is utilization management, which you guys may not have ever heard that term, but you have experienced it. If you've ever made those phone calls to insurance companies for authorizations and whatnot, UM is basically a process in healthcare that's meant to ensure that medical services and resources are used appropriately, efficiently, effectively, and also providing good quality of care. So sort of the other side of the equation, some people with medical backgrounds, physicians will do this quite a bit when they're, just get burnt out from the healthcare system. So that's an option. Expert witness work. There's tons of CMO medical director jobs out there for various companies that need people with medical backgrounds. Entrepreneurship is another big one. Healthcare startups always need physicians and people with clinical background. So that's always an option as well. Biotech, pharmaceutical companies, if you have any work with clinical trials, There's always opportunities for that. There's tons and tons of jobs out there. I mean, honestly, just a simple Google search by itself can yield a lot of opportunities that you would have never even thought as an option. But the point being with this is, there's also non-medical work, like you can go back to school, people have gotten JDs, and so there's a lot of options out there. Just always remember that you're a highly skilled and sought after person. Even if you don't do clinical medicine, don't feel like that's the end of your career. There's always opportunities out there. You're smart, you're highly trained, you're very capable, and you're in demand, whether you realize it or not. So even if you decide clinical medicine is not for you, it's okay. Don't feel stressed about that. I apologize. We ended up going way over time, but I think it's all very relevant information. All my contact information is up there. Feel free to call me, text me, email me. And when I say 24/7, 365, I mean it. I'm very passionate about all this kind of stuff. If there's anything that I can do or any of the other speakers can do, I'm happy to be a resource to connect people to them as well. Feel free to ask. I know we kind of ran short on time. I'm happy to stay on through the session if anyone has any specific questions to answer or questions that I can address for you. Otherwise, you can certainly call me or text me, and I'm happy to spend whatever time I have available you need to help you address your concerns and questions. A lot of the stuff that Dr. Bonne had mentioned also will be addressed in sessions 2 and 4. So feel free to kind of attend those, but even if not, if you don't have time, you can call me or text me anytime, and I'm happy to address. But anyway, I thank you all for attending. Hopefully you found some value in it. Feel free to spread the word to your colleagues if there's value. Anybody in training, but certainly people within the last year of training, I think it's most relevant to. But I thank you all for taking the time. I appreciate all the speakers taking the time to give you all this valuable information. And hopefully you found value in it. And I look forward to seeing you guys in the next sessions.